Good evening, everyone. Uh, we welcome all our attendees to this, our very first webinar of 2023. We will be starting very shortly, and we're very pleased to have with us a distinguished speaker today, Dr. Suraj Bramhane. He is the MD Pathology, Laboratory Director, and Consulting Pathologist at Cleantech Laboratory Private Limited, Navi Mumbai. Dr. Bramhane comes to us with a host of experience, a wide-ranging experience covering multiple sectors in the medical sector. His extensive experience today has come to the fore as he has politely consented to share his learning on the subject of hepatitis C diagnosis. We're very pleased to have you with us, Dr. Saab, and we extend a very warm welcome to you. We have about 40 plus participants, so I believe we could start with it, your presentation at this point of time, sir. Over to you.
Yeah. Thank you very much for the introduction, and thank you so much for having me. We'll be discussing this topic of hepatitis C, which is quite a common occurrence here in India and even across the globe. It has it has a lot of implications, because this is such a disease which has a very chronic phase, and it poses a lot of challenges to clinicians and pathologists and microbiologists similarly, to diagnose and just to in a sense get a hang of what exactly to be done at what stage and how to identify and how to proceed with the diagnosis. So we'll be discussing related to that shortly. So can we begin? Okay, perfect. So good evening, everyone. I'll be presenting this topic, a diagnostic guide for hepatitis C. Now, as the American psychologist and philosopher William James very rightly said that, is life worth living? It all depends on the liver. Now, we all know that the liver is responsible for a lot of processes in your body. It is responsible for synthesis of a lot of macromolecules. It is a storage organ, and it is also a detoxification plant, so to speak, for the body. Introduction. Now, first diagnosed in 1989, the hepatitis C virus is a significant public health problem, which is affecting more than 185 million people worldwide. The percentage of people who are seropositive for HCV antibodies is estimated to have increased from 3 to 2.8% in the past decade. Most patients who become acutely infected cannot clear the virus and ultimately proceed to chronic infection. The effects of chronic infection include cirrhosis, portal hypertension, hepatic decompensation with encephalopathy, and hepatocellular carcinoma. Now, quite recently, Michael Houghton, Harvey Alter, and Charles Rice were awarded the 2020 Nobel Prize in Medicine for their fantastic feat of discovery of hepatitis C. Because earlier to 1989, it was classified as a non-A, non-B virus because it did not exactly fit the spectrum of either hepatitis A or hepatitis B. Because of the limited amount of diagnostic techniques or research methodology present, so ultimately in 1989, these three gentlemen were able to isolate the hepatitis C virus, and which became part of, which actually really led to a lot of research and development, and even to the development of drugs, ultimately for the treatment of this, disease. So we'll just come to the etiology. HCV is a spherical envelope positive stranded ribonucleic acid virus. So it's basically an RNA virus, which is 55 nanometer in diameter. It is a member of the family Flaviviridae, and it has its own separate genus, Hepacivirus, because it's even though it belongs to the family, it's a bit distinct from the Flaviviridae. So it has its own genus, that is Hepaciviridae. The genome is approximately 9.6 kb in length, and it encodes polyprotein that gets processed into at least 10 proteins. These include 3 structural and 2 envelope proteins, and 5 non-structural proteins. So these are, you can just have a look here, the 3 structural and the 7 non-structural proteins. Structural proteins being C, E1, E2. The non-structural proteins being NS1, NS2, NS3, NS4A, NS4B, NS5A, and NS5B. The non-structural proteins are the ones who are utilized for the targeting. So these are the non-structural proteins are the target for your DAAs that is the directly acting antivirals for hepatitis C. And these non-structural proteins, they are involved in the multiplication of the virus. So this particular segment is the one where the majority of the drugs that have been developed and even in development right now are utilize this as a target for achieving your treatment for the hepatitis C infection. Now, looking at the epidemiology, we'll start with the worldwide epidemiology first. In developed nations, HCV prevalence is typically 1 to 2%. And of these, of the 3 types of viral hepatitis, there is A, B, and C. HCV accounts for the greater number of deaths and higher mortality in Western countries and in developed nations. HCV transmission requires that the infection, the virons, they contact susceptible cells that allow replication. And HCV RNA can be detected in almost all the bodily fluids, your blood, the serum and plasma, saliva, tears, seminal fluid, cytic fluid, and CS. So it's basically secreted in all the bodily fluids, but then blood is where you usually target for identification of HCV. HCV may be transmitted during sexual intercourse, but this is a rare occurrence. It's more likely that the contraction of hepatitis B would occur by this route. Vertical transmission frequency ranges from 1 to 4% and is and in more extensive studies. It has been also that the intravenous drug abuse is the most common method. Is the most common route of infection in developed countries, and also poor medical practices in resource-limited areas of the world. Now, coming to the subtypes, 1A and 1B are the most common genotypes which are prevalent throughout. Now, we'll direct our attention to the Indian epidemiology area. Now, considering an emerging, it is considered to be an emerging infection. There is a lack of existing literature on the true prevalence on the general population due to paucity of well-designed population-based studies. So in a meta-analysis of 327 studies, the prevalence was estimated to be 0.85 in community studies, 0.44 in asymptomatic blood donors, and 0.88 in pregnant women. Estimated percentage according to the consensus, the general consensus that all the practitioners in India would, it is around 1 to 1.9%. Now, in a country with 1.35 billion individuals, 1.9% represents a very significant number. So there's a huge burden of this disease. HCV genotype predominant in India is type 3 and type 1. So type 3 accounts for approximately 60%, and genotype 1 accounts for 30% of the infections that we have here in India. And all-cause mortality, sadly, the progression to cirrhosis and development of hepatocellular carcinoma, it is most likely seen in patients with genotype 3. So you can understand by this that the genotype 3 is the most prevalent type of genotype in India, and that is why the incidence of cirrhosis and cancers, that is hepatocellular carcinoma, is higher as compared to the rest of the world. So that means that we have to be even more vigilant while diagnosing and classifying patients who might be having hepatitis C. Now, pathophysiology, the transmission, as we discussed earlier, is intravenous drug usage and infected needles, vertical transmission, sexual contact, unclean tattoo, infected blood, and needle prick in healthcare settings. So just quickly, I forgot to mention a point where in so basically in 2001, the Indian government made it compulsory for testing of HCV to be included in blood donors. So that is why a lot of patients were, a lot of patients were diagnosed after that. So that really, that one decision really helped a lot in identifying the disease load of this hepatitis C in India. And yeah, so so basically, unclean tattoo, infected blood, and needle pricks in healthcare setting, they account for transmission. The incubation period is a median of 2 to 12 weeks. The average time for infection until seroconversion is 8 weeks, and this period is referred to as the serologic window. Now, coming to the signs and symptoms, they include your signs and symptoms of liver failure, liver disease such as fever, fatigue, high colored urine, clay colored stools, abdominal pain, loss of appetite, nausea, vomiting, joint pain, and jaundice. Extrahepatic manifestations include diabetes mellitus, glomerulonephritis, essential mixed cryoglobulinemia, porphyria cutanea tarda, and non-Hodgkin's lymphoma, and neurocognitive changes. Now, we'll be coming to the pathogenesis. Pathogenesis, we'll just quickly summarize it because it's quite in detail. So we'll just touch upon the very important points. Direct cell injury due to viral replication is the first mode of development of the disease. There is a rapid replication of virus particles. So once the patient is infected, the virus is going to be very rapidly replicated in the virus in the liver tissue, in the hepatocytes, and it will ultimately lead to the damage of hepatocytes and the hepatic tissue. This will lead to hepatic steatosis, oxidative stress, and insulin resistance as a direct result of multiplication of these virus particles. Uh, when so after that, the second mode of injury would be immune-mediated cell injury. So once the virus is multiplied in the liver tissue, obviously the body will start its immune attack to contain the infection, and it will release CD4 and CD8 lymphocytes, which will be seen in portal vein, periportal, and lobular areas and cause damage to the hepatic tissue. Because of these antigen antibody complexes which are developed as a part of the constant battle between the virus and the immune system of the body, the various immune complexes will be deposited in the virus and in the extrahepatic tissue subsequently. I mean, the immune mediated cell injury will take a little time, but then eventually it will set in, and as the disease progresses and if no treatment is taken, or if the patient has other pre-existing conditions such as HIV, maybe cancer, or taking immunosuppressives, in such cases, the immune-mediated cell injury will be, in a higher degree and cause a lot of, complications which will occur, and further damage to the liver tissue will occur. Now, NS5A and E2 regions play an important role in the very evasive mechanism of the virus, and resulting in resistance of pegylated interferon alpha, which is used for treatment. Now, the pegylated interferon alpha was developed and available in the market. So, yeah. So HCV genome is a single host. Although it's a single host, we have something called as quasi species, which are after during multiplication, the virus. No two virus will be exactly the same. They will be of the same species, but there will be a little variation in their genome. And that is why it is classified as a quasi-species. And the generation of quasi-species is usually ascribed to the high variation in the HVR1 region during replication. So this HVR1 is responsible for developing these quasi-species, and that is why you can imagine that because there is going to be a subset of different quasi-species, it becomes very difficult for the immune system to mount a solid response uh, towards this infection. The role of HCV genotypes in the progression of liver disease is one of the most controversial topics, in the research of HCV. So it's better that we leave it to the researchers as we move ahead. Now, the natural history of HCV is in a population infected with HCV. It is observed that 15 to 45% of individuals they will spontaneously clear the infection within the first 6 months. So we can consider these to be really lucky individuals. Maybe they have a fantastic immune system and nutritional status, and not just maybe just a good genetic genetic makeup, and the remaining 55 to 85% of the individuals they will follow a chronic course, often lifelong, without treatment. In acute phase, 70 to 80% of the HCV infected individuals are asymptomatic and mostly unaware about the infection till it reaches a chronic phase. Now, of the infected individuals, 75 to 85% may develop chronic infection, whether advance into liver fibrosis, cirrhosis, extrahepatic complications, and hepatocellular carcinoma. Now, the characteristics of persistence of HCV infection and development of chronic infection may differ from individual to individual. Now, this will be dependent upon age, immune response, degree of inflammation, HIV, hepatitis B co-infection, lifestyle habits such as consumption of alcohol, maybe drugs, or other associated factors. Now, the average time taken for the development of chronic hepatitis is around 10 years, with an estimated of 10 to 15% cases progressing to liver cirrhosis within the first 20 years. And of these, in 15 years, they may hepatocellular carcinoma. Now, coming to the high prevalence, patients with HIV infection requiring multiple transfusions, individuals with high risk sexual behavior. Now, these will form, a subset of population where the possibility of finding HCV is going to be from 3.5 to 44%, which is quite a huge number. The prevalence of 7 to 76% is seen in HIV. So, HIV, more than likely, it is possible that HCV will be.
I'm very sorry. I think we experienced a small technical glitch. Please don't go anywhere. We'll be back in a minute. I think Dr. Bramhane is just reconnecting. Dr. Bramhane, we can't hear you, sir. Your connections, audio connection needs to be reset.
Yeah, really sorry for the internet issues. There seem to be some problem. So can you just quickly tell me? I think I had moved on to the high risk prevalence. Was this the last slide that you were able to hear?
I think you can go ahead, sir. I think we were a little ahead of this.
Okay, so we'll just begin with this slide again. Now, patients with HIV infection receiving hemodialysis, intravenous drug users, patients requiring multiple blood transfusions. Pardon? Yeah. Okay. Am I audible again? There
Yes, sir.
seems
You're
to be
audible,
some
sir.
problem.
You're audible, sir.
Okay. So I'll just continue. So, so testing of all donors for HCV was made mandatory by the government of India in June 2001 to ensure prevention via blood and component transfusion. Nucleic acid tests are highly sensitive and specific for the detection of HCV among blood donors, a bit costly, but until 2017, barely 2% of the blood banks in India have facilities for NAT. And limited resources showed HCV positivity rates of 1 in about 5,400 seronegative samples. Now we'll move on to the laboratory diagnosis. So now the approach to testing for HCV is presented here. Now the first will be your routine tests, that is CBC, LFT, GGT, and other baseline tests in suspected cases. Your screening tests for hepatitis C, which is done with a serologic test for anti-HCV antibody. The confirmatory tests, which will require the presence of HCV RNA, and this is called as hepatitis C viral load. The fourth will be genotype testing. That is, once it is determined that the HCV RNA is present, the specific genotype and subtype of the virus can be determined with a genotype test. And lastly, drug resistance, that is mutation of some proteins in HCV, which can allow the virus to have resistance to directly acting antivirals, commonly referred to as RAV, that is resistance associated variants, or RAP, that is resistance associated polymorphisms. Now, coming to routine tests, in CBC, the general finding will be anemia due to erythropoietin suppression, which will be caused by secondary renal failure, or hemolytic anemia as a result of HCV, anti-HCV treatment. The LFT will show bilirubin, which will be raised in acute and chronic phases, but not very high as compared to other hepatitis. Uh, Fluctuating levels will be observed throughout the course of the disease. Now, ALT will be raised 6 to 10 times normal in the acute phase and usually elevated during chronic phase. AST will be higher, will also be raised, but it will be lower than ALT. In drug therapy, alcoholics, cirrhotics, AST will be higher than ALT. Now, albumin will mostly remain normal, but it will be decreased in cirrhosis. And your alkaline phosphatase and GGT, your gamma glutarate transferase, which are enzymes of the liver, they will mostly remain normal, but they are helpful in assessing the liver function and progress of chronic hepatitis C. And levels will be raised during secondary infection of liver or secondary damage, due to secondary conditions such as drugs or alcohol, or even during follow-up for treatment when patients
Um, Sorry again for the technical glitch, but I believe Dr. Bramhane had just started the discussion.
I'm really sorry. There is seems to be some
Fine, sir.
problem in the internet. But
Sometimes,
yeah, am I audible now?
yes, sir, loud and clear.
I mean, I can see the connection is like again, I can see all the bars, but the Wi-Fi, but it's still. I don't know. So can we continue?
Yes, please continue, sir.
Yeah. So along with clinical features such as encephalopathy, ascites, bilirubin, PTINR, and albumin, these are useful for child pug scoring for liver disease severity, which is used by clinicians a lot while classifying the disease. Now we come to the screening tests. The HCV antibody test is used for initial screening for hepatitis C. The test is performed by enzyme immunoassays, which detect the presence of hepatitis C antibodies in the serum. ELISA, ELFA, CLIA, and lateral flow tests are the methods of screening. Now, just quickly touching upon ELISA. ELISA is used in blood banks. After a blood donation camp is over, all the blood bags that are collected. So the method of choice in such conditions is ELISA. But then when we come to our routine diagnosis in your normal urban and rural settings, lateral flow and immunochromatography are the ones which are utilized the most across majority of the labs in India. Now, the third generation EIAs have a sensitivity specificity of approximately 99%, which is excellent. The government of India has actually mandated the usage of third generation EIAs for screening of hepatitis C, according to a 2018 guideline, which was released by the Ministry of Health and Family Welfare. Now, obviously, because these are screening tests, they are going to have their drawbacks, and here the drawback is going to be it cannot differentiate between acute, chronic, or resolved hepatitis C infection. Here you will be encountering false negative. False negatives will usually be seen when the patient is in a window period, incubation period. Patients who are immunocompromised or who are going immunosuppressive therapy of some sort, and false positive usually will be seen in cross reactivity with other viral antigens, such as immunological diseases such as lupus or rheumatoid arthritis. Fourth generation EIAs are available in the market. They employ a combined antigen and antibody approach, and they also have an excellent sensitivity and specificity. Many centers do use these as well. But then third generation EIs usually are sufficient for screening purpose, because ultimately, if the test is positive, you have to confirm it with nucleic acid amplification techniques, right? So coming to the confirmatory tests, nucleic acid amplification remains the gold standard for the laboratory diagnosis of hepatitis C. Now, let's say without a nucleic acid amplification based test, which has said that hepatitis C is detected, just based on the screening test, you cannot classify a patient to be HCV positive. Now, the presence of HCV RNA is required to confirm, and therefore, positive HCV RNA must be followed by a test with HCV RNA. HCV RNA is usually detectable within the first 2 weeks following exposure of the virus. Now, we'll just quickly summarize the 4 major reasons why HCV RNA are recommended. They are recommended to confirm a positive HCV antibody result, to measure a patient's baseline viral load prior to initiating HCV therapy, to monitor a patient's response to therapy, and to determine whether a patient has achieved a sustained virological response. So, sustained virological response in terms of HCV is when we say that the patient has been cured. So, this is a term which is used only with respect to, it is used with respect to HCV, that when the treatment is done, the sustained virological response means the patient has been cleared of HCV. Okay, so this is just a summary of the timeline and the laboratory events that take place during a regular course of a patient who is infected with HCV. Now, on the x-axis, you can see once the patient at 0, he has contracted the infection, and as it progresses, you can see 3 distinct peaks of the ALT, where this will keep rising and falling, rising and falling. But obviously, of course, the severity will be lower and lower in every step. So in acute phase, it will be very high. In chronic, it will be medium, and in cirrhosis, it will be at a lower level. Once anti-HCV, which usually becomes positive by the 3rd to 4th month, it will continue to remain lifelong. And HCV RNA will continue to remain so. All right. Now, this is a practical guide which, all the clinicians and all the pathologists should, this is just like a very quick ready reckoner for, interpretation of the test. So, if you perform a HCV AB, HCV RNA, If both are positive, then you can say that there is presence of infection. If the HCV antibody is positive, then you are looking at a false positive or a patient who has resolved hepatitis C. If the hepatitis C antibody is negative, HCV RNA is positive, the interpretation would be it could be an occult infection, immunocompromised host, or the patient might be in a window period. And if both are negative, that means you can say for sure that the patient has no infection. Now, this is another classification guide. Now, antibody test. Now, if a patient is prior cleared HCV infection, in such a patient, the antibody test will be positive. The HCV RNA will be undetectable on two tests performed 6 months apart. And the ALT will be normal, fluctuating, or persistently raised. In acute HCV infection, the antibody test may be negative because it will usually come positive after 6 to 24 months. The HCV RNA will be detected within the first 2 weeks of the infection, and the viral load in such case will be very high, and the ALT will be 7 to 10 times the normal value. In chronic infection, antibody test will be positive, and the HCV RNA will be detected, and again, normal, fluctuating or persistently raised levels of ALT will be seen. Now, coming to genotyping, now these are, there are at least 6 HCV genotypes, as we have seen in etiology, type 3 being most common in India. There are 6 genotypes, 1 to 6, and 70 subtypes of HCV, which are referred to as 1A, 1B, 2A, so on and so forth. Now, these are essential from the point of view of treatment for the patient, because the genotype is going to be very helpful in preparing a regimen for treatment of such patients. Right. Now, the genotype for diagnosis is mostly determined by sequencing of genome nucleotide by kit-based assays, which employ complementary probes to report the genotype present in a specimen. Sequencing of highly conservative regions such as NS5, 4, E1, and 5' UTR is the most recommended HCV. And can have problems in case of mixed infection. Now, what is mixed infection? Mixed infection, sometimes what happens is the patient may be infected with 2 different genotypes or 2 different subtypes of the virus. And that is where, there are going to be a lot of issues related to genotyping and response to therapy. Now, genotyping can also be accomplished by RT-PCR, next generation sequencing, MALDI-TOF, RFLP analysis, and NGS is effective in generating the whole HCV genome accurately. And simultaneously, it can also determine the HCV genotype, subtype, your resistance associated substitution, and also quasi-species. So, as you can see, that NGS is a very fantastic, method of choice for genotyping, because it is going to give you a very comprehensive picture of what type of exact HCV infection you are looking at. And, whenever the patient will be referred to a gastroenterologist, they will be the ones who will be, ordering these tests. And based on the results of these, they are going to prepare a treatment regimen for the patient. Right. Now, coming to drug resistance. Now, interferon-based ribavirin was the mainstay of treatment prior to 2011. Now, directly anti-hepatitis C virus, that is DAA, they were developed in 2011, and they target the steps in the life cycle of hepatitis C virus and prevent the replication. So, as we had seen earlier, so we will touch up on this in the next slide. It will direct the various steps in the life cycle of multiplication of hepatitis C virus, and it will prevent its replication. Okay. So these include NS5A inhibitors, NS5B polymerase inhibitors, and NS3 4A protease inhibitors. Now, RAV testing is done to most patients who have failed prior DAA containing regimen. So basically, patients who have not responded very well to your DAA, in such patients, RAV testing is performed. And genotyping of NS5A, NS5B, NS34A genes to identify RAVs can be accomplished by RT-PCR and population-based sequencing. Right? So here, as we saw, so the mechanism of action of DAA is summarized in here. Here you can see the 5' 3' end of the region encoding the polyproteins. You have the first three structural proteins. Now the drugs, they are only concerned with the non-structural proteins, NS3, NS5A, and NS5B, to be precise. So these three are going to be the targets for treatment. Why? Because non-structural proteins are involved in the multiplication of the virus particle. Okay, and then coming to liver biopsy. Now, liver biopsy plays a critical role in the management of patients with viral hepatitis C. In patients with acute viral hepatitis, a liver biopsy is, although very uncommonly performed, it can help to rule out other non-viral causes of deranged liver function. In chronic viral hepatitis C, it is considered the gold standard in the assessment of degree of necroinflammation and the stage of fibrosis, and to help guide treatment and determine the prognosis. It also helps to rule out any concomitant diseases such as steatohepatitis, hemochromatosis, or others. And in patients with chronic progressive liver disease with cirrhosis and dominant nodules, a targeted liver biopsy is very helpful to differentiate a regenerating nodule from a dysplastic nodule or HCC. So, liver biopsy generally will be, ordered by a gastroenterologist, and they will be, the ones who will be deciding. Because a lot of times, what will happen that hepatitis C may have reached such a stage that it has come to maybe there is additional damage or additional infections or additional underlying conditions that the patient is having. So in such cases, liver biopsy plays a very major role. And we have your Ishak modification of nodal staging, which is used in liver biopsy, which was developed in 1995, which is the standard staging system which is used by pathologists, gastrointestinal pathologists worldwide. Other systems which include Schuler system and Metavir system, but these are less commonly used. Okay, so quickly touching upon the various histopathological features, I'll not be going into the details. I'm just touching upon the very prominent ones. There'll be portal inflammation, interface hepatitis, lobular inflammation, portal lymphoid aggregates, bile duct damage, steatosis, iron deposition, and fibrosis. So now we'll be moving on to one of my favorite part of the discussion, and one of my really something which I'm really involved in because I'm into digital pathology, and I've been studying artificial intelligence and machine learning based approaches in diagnosis, in histopathology, in cytology, and also in the interpretation of laboratory data. So artificial intelligence, unless you've been living under a rock, everybody is well aware, at least know what artificial intelligence is and how it has affected all the fields across multiple disciplines, including medicine. So CAD, what is CAD? CAD is computer aided diagnosis. Now, artificial intelligence holds immense promise in prediction, diagnosis, and improving patient outcomes in HCV. Machine learning based approaches for laboratory result interpretation and reporting of HCV can be deployed. Thereby, it will be minimizing operator based errors. Now, basically, excuse me just a moment. So basically, we have a lot of centers, a lot of healthcare providers and specialists are not available to everyone everywhere. Right? Now we are all constantly generating data. So let's say, for example, we are there are certain patients who are HCV at a very interior place or remote place. If they are just able to get a test done, but they are not able to interpret. In such cases, and in such cases, artificial intelligence holds a very major role, right? So how it will help? It will minimize the operator-based errors. Now, values in target variable in the data set are included to transform the categorical values into integer values. So I'll just quickly explain what this means. Now, let's say, for example, we have received 50 HCV samples today. We have tested them and all the results are available. But maybe we have received these from multiple centers. So we have to classify them, right? Now, this is achieved with the help of, there are programming languages, and the one which is most commonly used for artificial intelligence is Python. So here what we do is these values are fed into the, um, into the, into the data set. Okay. And this data set is classified, it is given numbering. Now the computer, it cannot understand numerical values, but it will understand, it will not understand alphanumerical values, but it will understand the numerical values. So for example, if HCV is negative, we will assign it 0. And if HCV is positive, we'll assign it as 1. Now all this is achieved with the help of a programming language. And this is done by data interpret, there are directly, softwares which are available, which will just scan your report and directly feed the information into the system. And the data set is then divided into 3 parts. Okay. Now this is very interesting. Now, now this will, so basically machine learning is a part of artificial intelligence, just as pathology, microbiology, and radiology is a part of medicine, right? So ML is a subset of artificial intelligence, which can be used in medical purposes and in diagnosis for our purposes, particularly. So here what we'll be doing is, we'll be creating 3 data sets. First is your training set, second is your validation set, and third will be your test set. The first will be testing, and the secondary will be testing it on, field. Okay, so I'll just, maybe it's a little complicated, but I'll try to simplify it as much as possible. Training set means that you take one particular set of data, and that data will be used for training the algorithm of the machine learning. So, for example, in the machine learning algorithm, as you can see, multi-layer perceptron, random forest, and decision tree. These are 3 examples of your algorithm for for machine learning. So you will take one training set, that is one set. I will take one set of all the patients who are HCV positive. What is their HCV quantitative? What is their genotype? What is their drug resistance? And I will feed it into the training set. Okay. Now this training set, once it is complete, then we'll take the validation set. Validation set will be, it is something similar to our quality control set that we provide, right? Quality control or ECAS, wherein we have a known, a known value. So this validation set will be provided by an earlier operator who has worked on this set. So you can compare it with, it is similar to QC. And the test set is the test results that you will be getting for interpretation. Okay. Now to ensure the uniformity, all this data which is gathered, it will be normalized on a scale of 0 to 1. Now this normalization means that, so normalization is very important, right? Because all the different laboratories, they'll be using maybe different units for interpretation, different normal ranges depending upon what analyzer that they are using. I'm talking in terms of quantitative, right? So you have to uniform normalize this data 0 to 1. So this is part of data cleansing, where you are feeding normalized data to the ML set, and here when it is fed into these ML models, it will give you the results which will be based on accuracy, specificity, and sensitivity of each algorithm. So now, as we speak, now this is actually one of the studies which has successfully concluded the application of artificial intelligence in the diagnosis of HCV. Now, all the algorithms here, as you can see on the right side, the summary, the random forest classifier, multi-layer, and the decision tree, the accuracy consistently is more than 80%, which is huge. And the specificity is also in the range of 80s. And the sensitivity remains 100%. In multi-layer, there has been a error, which, but then again, that also is 100. I think by mistake, they have written 0, but it's actually 100. The sensitivity has been found to be 100%. And this has been published in the Journal of Gastroenterology. Now, investigators propose that using AI and ML-based techniques in the diagnosis of chronic HCV can improve diagnostic efficacy by minimizing the interpretation errors and delays in reporting results, thereby facilitating prompt initiation of treatment. And so basically that was about AI-assisted diagnosis. Now, in conclusion, just quickly touching up on the main headings that we've discussed. HCV is a major cause of liver disease. Chronic disease leads to morbidity and mortality. Screening and diagnostic techniques are available which are rapid, reliable, and economical for early detection, treatment, and follow-up. Third generation antibody assays are the cornerstone of HCV screening, while HCV RNA by NAT is the diagnostic test of choice. Genotyping is available in more and more centers and is vital in therapeutic interventions and modification to regimen. Sorry. Am I still audible? I think my
yes, doctor, you're audible. It's just that your screen, your presentation seems to have finished. Were we at the end?
It's yeah. So I'll just carry on ahead from here. I mean, I don't necessarily need to, but I'll still just, because there are references and thank you slide. So excuse me. Okay, is my slide visible now?
Not yet, sir.
Okay, fine. I'll just continue then. Now, genotype is available in more and more centers and is vital in therapeutic interventions and modification to regimen to improve patient outcomes and achieve sustained virological response. Resistance-associated variants refer to mutations that occur in target enzymes that confer resistance to the DAAs. And AI-assisted diagnosis and predicting patient outcome holds promise for the future. These are the references. And thank you so much for having me and letting me present this wonderful topic of HCV.
Thank you very much, doctor. Thank you very much. In fact, you were rather quite extensive. I figured your, that area of interest. Everybody knows the basics of HCV. You covered that in great detail, of course. But I was really impressed with your thorough knowledge on the concept of machine learning, getting into Python, specifically related to the data set, validation set, and the test set. And those are, of course, those are the basics of all AI and machine learning working programs. but how it's been applied to something in the field of HCV diagnosis gives us a good sign for the future. And given the fact that the WHO has put up has set 2030 as the target date for elimination of HCV on a global scale, a lot of countries today have their national elimination programs, the NEPs, in place. You've been observing things in India, and what do you think are the challenges we face here with respect to effective HCV diagnosis, or more specifically, with regard to the future of HCV diagnosis? How do we look at, if we need to eliminate HCV, what do you think, a couple of steps that you think we could do, the government could take note of, and or maybe we'd hit the target in 2030?
So I think the first and foremost step that the government needs to take is basically, use nucleic, just all the blood banks in the country need to have NAT, that is nucleic acid amplification techniques, to be, compulsorily available for all screening of the donors. Because although we are utilizing ELISA for all practical purposes, it's a very old technique. It has its own drawbacks, and it's just time consuming, and it's just like, for me, I mean someone who's involved in AI, for me it's it's an artifact, it's an old, probably being kept in the museum, right?
Absolutely.
We have to look ahead. We have to move beyond ELISA, because ELISA, it's still applicable for a disease which is so prevalent, such as HCV. Utilizing ELISA in blood bank is just, it's not at all advisable at all. You look at all the developed countries, nobody is using ELISA for diagnosis of HPV or HCV anymore. That remains to be the first step. The second step will be, extensive genotype studying of the population. Population studies of genotyping is very important. And for that, maybe the government needs to come up with public-private partnership programs for, since we have had so many COVID laboratories set up, the PCR laboratories are available by the dozen in every district. Maybe that can be put to good use by implementation of, HCV screening or any other, for this purpose for HCV and all such data, there should be a central database which has to be obtained by the government, where we can actually, apply the data set that while application of AI, and that will give us a very good validated data set, and which ultimately, if the government is able to help with that, maybe such algorithms can be monetized by the government as well. But then you require that sort of leadership and foresight from the government to actually involve people from this sector, and people from the intersection who are in medical and in machine learning and AI, to actually come together and deploy these techniques. The third would be just your general education. But then because of the people have become really because of the availability of internet and smartphones everywhere, and just basically, I think after COVID, everyone is really really looking forward to, they spend a lot of time on their health. They take things very seriously when it comes to health. Everyone knows what's hepatitis. Even kids nowadays, they know what is what. So this change eventually is going to get reflected into the target that you set, that 2030. It definitely looks like, but then we don't know how ultimately it has own evasive mechanisms. It's good to set targets, but definitely we cannot underestimate the sort of organism that we are dealing with here. And that is why constant surveillance and constant, upgradation of methods and practices to diagnose, to screen, maybe, employ HCV, HbACG, maybe use multiplex testing. So, multiplex testing is something which a lot of, manufacturers have started doing, wherein, with one sample, you can test for hepatitis B, C, HIV and multiple cases all at once. So if something like this is employed, I think that will be, one of the major, instruments by which we'll be able to
Well, to be
sort
very
of,
honest, sir,
limit the spread of the disease.
there was a company called Theranos in the US, and they did
Yeah,
start
that
with
will
that
be a
concept, but
scam.
it went down the wrong way, of course. It didn't end well
Yes.
for them, but yes, they did try to come up with that concept of one sample and testing it for everything. Probably it would have been a miracle, as I call it, a miracle diagnostic test. It didn't work, unfortunately. Very sad. But I'm sure that once human beings get started on a particular road, we always end up in the right direction. Well, that being said, there are a lot of things, especially with HCV, because, like you said, there is the PCR test, which is the gold standard. But I'm speaking from the perspective of a person who has been looking at the HCV testing over the better part of about 1.5 decades for now. Less than you, of course, sir, but I've just been looking at it strictly from a diagnostics point of view. I have found that there are severe discrepancies between one brand and the other, one test and the other. It leaves the diagnostician with a sense of, how do you call it, unsurety. You're not 100% sure no matter what you give, whether it's positive or negative. Like, for example, let me understand. There are times when you get false negative cases on an HCV antibody test, even though the person has been exposed to HCV. There are things like that which happen, and that erodes confidence. That erodes confidence in the testing process. So when you did this, are there, if you have any inputs on that, under what circumstances would you get a false negative HCV antibody test, even if a person has been exposed to HCV? It's possible, right? That even when I'm exposed to HCV, when I run the test on an ELISA or on a rapid test, which is the standard testing mechanism, I may still come up as a false negative. So under what circumstances could something like that happen?
Now, false, you're talking about false positive, right? False negative.
Negative, sir. False negative.
So false negatives usually will be, a patient who is immunocompromised, or he's suffering from certain, collagen vascular diseases for which he's taking immunosuppressive drugs, or, in patients who are actually HIV positive. In such cases, also false negatives have been seen. And of course, window period, if patient is in window period, or, a very early, the exposure has been less than 2 weeks. In such cases, you are bound to get false negative.
So what would be the baseline, when you're talking about viral loads, what would be the baseline viral load in, IU per ml for us, for a medical professional to start therapy towards HCV?
For therapy, I would rather not touch therapy at all, because that's not my expertise. But from a diagnostic perspective, it will be 50 international units per ml. So, yeah.
There was a step something you mentioned in one of your slides about Ishak modeling. That is something. Is it something I'm not familiar with? So I thought maybe I should ask you. Is it something that is prevalent across the country, or is it only in the US?
No, it's not, so basically, whenever a liver biopsy is performed for a patient, now when the liver biopsy is performed, the pathologist, they will, the histopathological examination will be done, and based on the findings of the biopsy, we have this model on the Ishak modification of nodal staging. So this is used by histopathologists, gastroenterologists, GI histopathologists. They are super specialists. So they usually use this model for classification, and this classification is based only on the findings of liver biopsy. They will not take into account any other findings. We have your child pug classification that includes your clinical features and laboratory. But in Ishak classification, that is reserved for histopathologists who will, classify all the findings based on the findings of the liver biopsy.
What would be there is a lot of cross-reactivity that we see in HCV, especially when it comes to diagnosis, right? What are the antibodies that are most prone to this kind of cross-reactive behavior? have we identified any antibodies as such which can lead to cross reactivity?
So basically, people with SLE, systemic lupus erythematosus, and rheumatoid arthritis. I mean, these two have been found to be culprits where the antigens, because of these diseases, they will cross react. And other immunological diseases, but these two being the main culprits.
SLE
I mean,
and
in
rheumatoid
patients who have,
arthritis.
yeah.
Lovely. It's important, sir, because I'm in the line of as a manufacturer of HCV tests. So we face these challenges ever so often. These are some of the questions we have actually faced from these are real world case questions that I'm actually posing to you, not as a test, but as a method of maybe getting an input from a medical practitioner, which we can share with other medical practitioners down the line. Eventually, this is an educational webinar, and we hope to
of course
share this to the maximum number of people. In fact, I'm really intrigued with the thought of machine learning, and I will touch base with you offline because I'm actually looking at how we could, work on this. Maybe have another webinar specifically designed around machine learning and medical diagnosis. Given your interest in this field, I believe you would be a good exponent of the art out here. So
yeah, I mean, as I said, it's it's something, and I'm actually working on. I'm actually consulting on multiple projects as of now, which are involved with image classification and also so image classification also, that is your artificial neural networks, where we are able to identify all the whole slide scanned images. So we will the annotated data set
in Bangalore. There is a company in Bangalore which is working on especially on slides images and using AI.
Yes.
So they're doing a lot of good work. Yeah, we had interacted with them in our last Tide webinar in December 2022. So they were on board as a speaker. So very interesting and very intriguing, of course. AI is the future. One cannot deny it. And it's being put to good use in some places. Right. So thank you very much.
Hopefully sooner rather than later.
Thank you very much for your time. Thank you very much for the effort you've put into making a presentation on the subject of HCV diagnosis. We would be sending you the hard copy and the framed version of the certificate, which our manager, Mr. JP Mishra, will be delivering to you. But in the meantime, please accept this as a small token of appreciation. Thank you, Dr. Bramhane. Thank you for your time and effort.
Thank you.
We look forward to more such interactions.
Thank you very much. Thank you very much. It's been a pleasure, and hopefully, we'll have a session sometime later.
Thank you very much, sir. And thank you all, ladies and gentlemen, for making this webinar a huge success. Over and out.
Yeah. Okay. Thank you, everyone in the audience as well. I thank you, everyone, for attending the lecture. And if you have any queries, you can always reach me on my mail ID, and I'll be happy to help.
Thank you, Doctor.